thank you very much for taking the time to meet with all of us here at the ATS, so the American Thoracic Society Conference, General Linda Singh and Dr. Noah Lechtzin. I think we have some very interesting things to talk about, but maybe first if you can briefly introduce yourselves, that would be, I think, a good place to start.
So I'm Linda Singh, and I'm a retired Major General. I'm a CEO and founder of a company called Kaleidoscope Effect. I spent more than 38 years in the military and did some very interesting tours in places like Afghanistan and Kosovo.
And I'm Dr. Noah Lechtzin. I'm a pulmonary and critical care physician. I work at Johns Hopkins, where I'm an associate professor of medicine. I direct the adult cystic fibrosis program there, and also our neuromuscular lung disease program.
Excellent. And as I said, I think it was a very interesting story how we all met. So maybe Linda, if you can take us a little bit through your journey of the last almost couple of decades, right? So it's been going on for quite a bit. So curious to hear more. Yeah.
So I think the interesting fact is that all of the time that I've had issues with my lungs since really since Afghanistan, because that's where it started. I mean, I've always had seasonal allergies, but after doing a stint in Afghanistan, my allergies became all year-round allergies. I started having severe dry eye issues, and then about 2 years after being back from Afghanistan, doing additional travel in places like Bosnia-Herzegovina, especially during the time that they were in the wintertime where they were doing a lot of burning because they use a lot of coal and a lot of wood to heat. I started having more severe issues in terms of breathing. I've never had asthma my whole life, and so that was something very new to me. And it really didn't hit me until I went to take my physical fitness test. Since I was leading the National Guard in Maryland, I like to be very much out in the open doing my physical fitness test. And that was really more to inspire a lot of our folks that had challenges doing the run, the push-ups, and the sit-ups. And I really tried to get them to see that even as a general officer, I have to meet the requirements. And it was in 2018 when I was taking my physical fitness test. I wasn't really feeling all that great. I had was just getting ready to head to Bosnia, so I wanted to get it over because by the time I got back, it would have been quite a bit of time. So I just wanted to get it out of the way, which was the norm for me. I'd just come in and say, hey, let's just do this. And since I wasn't feeling all that great, I was like, okay, this is not going to be my best score, but I'm okay. And I had a real hard time. I mean, the push-ups and sit-ups, I was able to get through them, but it was the run that hit me. I've never walked on my run. I've always been, they would joke because they would usually have somebody that would run with me and talk to me the whole time, asking me 50 million questions. And they're like, how can you do that? And so this particular time, it was very challenging. I mean, I wasn't really sure that I was going to make it. I basically ordered everybody that if I fell, unless I'm having cardiac arrest problems, do not touch me, because as soon as they touch me, then you have to redo it all over again. And so I was like, do not touch me unless I tell you I'm having some severe issues. And they were really scared that I wasn't going to make it. And if you could see how all of my folks were really afraid, because they're like, this is not like her. So when I finished and I was able to, I passed, but I barely passed. And then I went into meetings and they kept coming and checking on me. So, you have this steady stream of folks that went through the building that I wasn't feeling well, which was not like me. And they were like, ma'am, you need to go to the doctor. And so when I went to the doctor, what do? I went to patients first because that was the easiest thing to do because I was headed out on travel, and they gave me an inhaler. So I didn't take it seriously. I mean, I'm just like, okay, I have an inhaler. I'll use it as need be. But when I went to Bosnia, I was with a group, and we were really going up this mountainside, and it was steep, but it's not that steep. And I had to take a break. Like I couldn't breathe. I couldn't catch my breath. And it was embarrassing because I was with other general officers and they're just like, Linda, are you okay? And you don't look good. And I'm like, I'm not feeling very well. And I think that's when it hit me that I have a more serious issue here and that potentially my time is coming to an end, right? And I think for me, both my grandparents died of lung cancer. So just having that feeling of, oh my God, what is going on? I'm not real sure. So that's kind of a scary thought. And so then if I fast forward to doing speaking events, it really got to the point that my voice started to be affected. I get very, very raspy. My allergies get really, really bad. So a lot of times I'd have to clear my throat. And then with COVID, it just made it worse because everybody was just looking at me like, okay, she's got COVID. I'm like, no, I don't have COVID. And so I happened to be speaking when I was just, as I would normally do before I start, I would just say to everyone, I'm going to apologize now for my voice if it cracks because I spent some time in Afghanistan and I've had like what I consider to be this really sexy voice afterwards, right? Like it's a radio voice. And if it wasn't for me saying that, then I wouldn't have met you. And then I think it was the conversation with you that you asked me a very pointed question. And you asked me, had I ever seen a pulmonologist? And I'm like, no, why would I?
So at that time, were there other colleagues that were experiencing similar things, or were you pretty much all by yourself in situations like that?
Well, I mean, I'm sure there were other folks. It's a matter of who was in that group. Like, there were tons of people in Afghanistan during that time. And, one of the things that really, stuck out to me is that one of our senior folks who was there, he was a colonel. He was a runner, like we would run. He, because of his schedule, ran midday. Mm-hmm. And towards the end, he went down with a very serious lung infection. And when I say very serious, I'm talking very, very serious. I ended up with a respiratory infection while I was there. And so I kept trying to run earlier and earlier in the morning. And there's a point in which that becomes unhealthy because you don't go to bed super early. And so I started running at like 3:30 in the morning to try to beat all the stuff coming into the base, right? I know it sounds bad, but it's like, how do you get your run in? And you don't want to run in the midday because it's like so bad. And you don't want to run right at like 6 in the morning because that's when everything just kind of settles over and it takes a while to dissipate. And so I think there were other folks that had issues, but, we just chalked it up to the, the dust and, bad accommodations and, it's just what you deal with.
No, I was struck by the fact that indeed throughout the process you were never referred to a pulmonologist where it was obvious that there was something significantly wrong with the airway. So that's when we made the connection. And maybe Noah, if you can kind of, what was your first impression of the situation? Where was your head at? What did you see? The number of tests or the amount of tests or the kind of tests that were performed previously, and where did you see the major gaps that were very clear in a case like this?
Sure. So I think I met Linda in 2022. And at that point, I think you told me a similar history. And by that point, you were on a pretty good medication regimen for asthma, but were still feeling pretty bad. Still had very low exercise tolerance and shortness of breath. And I started to think, between the exposures that you described in Afghanistan and in Bosnia, along with just when the symptoms started, asthma is a very common thing, but it's less common for it just to develop in, when it did for you. It's not like you had childhood asthma that was a problem and then just sort of got worse. And I looked at some of the history, and you didn't have a whole lot of testing done, which was a little surprising. And I think very frequently, if you see a internist, they say, oh, you're feeling short of breath, it's probably asthma. unless you smoke, in which case it's COPD. And you get an inhaler, and some of the time it helps. And even for people who don't have asthma, I think there's a little bit of a placebo effect, and if there is some airflow obstruction, bronchodilators help, and so most people feel a little bit better. But you really didn't have a whole lot of imaging done. You didn't have a lot of pulmonary function testing done, and so between the inconsistencies of the history and when this supposed asthma began and the lack of information, I started to say, there is this growing literature on lung disease that comes from burn pits and other air environmental exposures. I think we need to look into this a little bit further. And that's when I saw you, got more complete pulmonary function testing and better imaging.
Right, so then we're lucky enough to be able to look at those images, because also from our end, where we develop the technology, it's also important to get access to some of those cases, to kind of be able to understand if there is added value of quantifying those images. And you mentioned before that prior to that there was a CT scan taken, but and that's another thing where a lot of improvement can happen, is that a lot of the quality of the previous scans is sometimes not high enough to extract all the relevant information. So the baseline scan that we were able to look at, we quantified it, and we have a lot of experience over the last 15 to 17 years looking at a lot of asthma scans. And it was very clear that it wasn't asthma. So when that became clear with the quantification, so Noah, how did you interpret the data, and what kind of treatment did you initiate at that moment?
Sure. So as I said, we obtained pulmonary function tests and also the functional respiratory imaging. And as you said, the initial read from the radiologist wasn't terribly informative. It described some nodules that we knew had been there in the past, but not much else. Yep. The pulmonary function test showed some airflow obstruction, which is helpful, but not terribly specific, because asthma looks like airflow obstruction. But the imaging, the functional respiratory imaging, showed some very distinct abnormalities in the most distal airways that was characteristic of something like bronchiolitis, which is what's been described in people with burn pit exposures. Yeah. And so based on that, unfortunately it's a difficult problem to treat, and there's not a lot of great options, but one of the easier, better options is what's called macrolide antibiotic therapy. So macrolides are the class of antibiotics like erythromycin and azithromycin, and they're very commonly used for all sorts of common infections like bronchitis and sinus infections. But they also, in addition to their antimicrobial properties, they have anti-inflammatory properties. And so they're well tolerated, and they actually are fairly effective in things like bronchiolitis. So I prescribed azithromycin, which is easy to take, 1 pill 3 times a week. Unfortunately, hopefully you can tell me how it's gone, but when I saw Linda back, she was feeling better and had improvement in some of her testing.
Yeah, and I think, so I did worry because I also have another autoimmune issue in terms of a type of gastritis. I was like, oh, what is this going to do to me? But I really haven't had any other effects as a result of taking the antibiotics. And so I make sure that I take my probiotics to try to keep the system healthy. But I think there is a difference. I'm not going to say that I'm perfect. I can't run at the pace that I used to. Definitely not without my inhaler, because I still feel like there's kind of like this ability to where I can't quite get the breath, and maybe I'm still, kind of at that point of not being able to expel enough to be able to take a really deep breath. So I'm trying to now force myself into this regimen of maybe breathing a little bit deeper as I'm exercising, and just trying to take it easy. And so what it has allowed me to do is to get back to interval exercising, and that works well because my heart rate doesn't get as high, my breathing doesn't get too high before I can then bring it back down and then allow it to go back up. And so that works well for me. I still have to use the inhalers, but I don't want to say that I feel completely normal, but I feel like as normal as I'm probably going to get, where I can go up a set of stairs and not have someone look at me like, what's wrong with you?
No, and we also repeated the scan, and it showed also tremendous improvement, which was associated with improvement in the lung function as well. Not completely normal, that's true, and I think there is still room for improvement, but also an opportunity, I think, for the drug developers, the treatment developers, to look into this problem more seriously, because it is probably a very inflammatory-driven disease, poorly understood, because it's not on the radar of a lot of stakeholders.
Yeah.
The physicians don't see it maybe that often, or don't even recognize it based on the conventional tests, but it's probably a fairly large group of people that suffer from this. I think the people that were exposed to burn pits, but also it's likely linked to air pollution in general, and that's also a massive group. So maybe going forward, Noah, where do you think that the next steps could be? What could we do to make sure that people like Linda improve even more? And also, how can we detect maybe the people before they become symptomatic, or before they get to a stage where, they become a little bit desperate because, they don't get the answers, they don't get the right treatment. So what can we do to kind of improve these things?
Yeah, well, I think, as you said, getting a better understanding about constrictive and obliterative bronchiolitis is an important step, because until we really have a good understanding of what's causing it, it's hard to understand how to treat it. But I think before we can get to that point, it's also a matter of trying to identify it and recognize how common an issue it is. And to that end, I think using things like functional respiratory imaging can go a long way, rather than just sort of saying, oh, somebody's short of breath, probably asthma, take an inhaler. I think having the thought to say, oh, a pulmonologist probably ought to see you, and you need better imaging, and think beyond just the most common things if things aren't getting better with the usual treatments.
Yeah, and I think for me, I was going to an allergist because I felt like, well, it's got to be allergy related, right? And so the allergist, I was like, well, should I do shots? Like, what do I need to do to get this to calm down? And the allergist is like, no, I'm afraid you're going to have to live with this. And so, but at no point did they ever say, well, maybe you need to go see a pulmonologist.
And why do you have an idea why that is? Is that the way the system works? Is that because it seems like a logical thing to do, but
yeah. I mean, I think it has to do with anchoring. Somebody sort of came up with the thought, this is asthma, and then and the pulmonary function tests were consistent with asthma, and so you just sort of go down that pathway and put on blinders and just don't think beyond that.
Yeah, and even though they did look at my CT scans, and the one thing they said to me is that, just keep in mind, and if anybody, looks at your scans, that you have nodules, I don't think that they're serious, but just keep in mind that you have nodules there, and you'll want to keep an eye on them. And I'm like, okay, they're not serious, but I need to keep an eye on them. I'm like, okay, well, I don't know what that means. And so that was really the only conversation that we had. And so, the worst part is that you keep using, all the inhalers, I'm using, nasal sprays, inhalers, you name it, and I've got like a whole, kind of counter full, and it just seemed to be kind of a horrible thing. And then the worst part is, I think for me, I don't even know that it was just the medications and not knowing. I think the worst part for me was the quality of life. Yeah. Here I am, getting into what should be a beautiful time in life where I'm getting ready to travel. For me to get on a plane, even now when I get on a plane, I come off, I sound like, I sound much more raspy than I am now. And so I think it has definitely affected the quality of life. And then it was taking what I would consider to be a mental toll on me, right? Like you're looking at someone that never had a problem breathing, never had an asthma problem. I could exercise like crazy, like I would do, these crazy P90X, and all these crazy things, right? I mean, that was my, my thing, is doing all this kind of interval exercise and high intensity, and I just had to stop. And that is like the worst feeling ever, and I'm sorry to kind of throw this in, but it's the worst feeling ever for a woman who is postmenopausal, right? And you've got all these other hormonal things going on, and then you can't exercise. It's like, it's horrible.
No, I mean, I can't understand, I can't relate to that part, but I can imagine that is like the other thing on top of everything else.
It is, yeah.
One thing that struck me, and I think that's an encouraging sign, is that we actually got, I think, your initial CT scans from you yourself through, I think, the MyChart system. So I think there is very positive evolution in that the patient has more access to their own data, and therefore is empowered more to keep looking if they want to for solutions.
Yeah.
And I think that will help to break down some of the silos and make the connections, because often also for us it's hard to get data from the radiologist, because there's a lot of data privacy, and rightfully so, but it slows things down. So the more the patient can get involved, the more they can kind of take ownership over their own health, the faster things can progress. So that, I think that's quite encouraging signs. And I was also struck by something that you mentioned, Noah, is that, can you talk about what you typically get from a radiology in terms of a visual assessment, and where you kind of see that we need to go from, let's say, a pulmonologist perspective to get the information that you need to make the most optimal decision for an individual patient?
Sure. So, nothing against radiologists. A smart, good radiologist is incredibly helpful, but their interpretation is very subjective. They look at the images and they describe what they see, and then usually give an interpretation of what sort of disease processes could look like that. But it is very subjective, and it relies on sort of what they see and what they're familiar with. Whereas the functional respiratory imaging is very quantitative, and it describes a lot of the anatomy that the radiologists don't really even look at. Most of the time, they don't describe the smaller airways or the blood vessel volumes. It's very much sort of, we see some shadowy areas here and some less shadowy areas there.
No, it's true. We had a discussion yesterday, and so my background is in aerospace engineering, and I told him we didn't send people to the moon based on something that somebody thought looked good. Oh, this rocket looks good, let's try it. No, we ran the numbers, and then we re-ran the numbers until we were sure it was going to work, because lives were at stake. And I think if you look in healthcare, a lot of lives are at stake. And often for people that serve the country, often people that are maybe in a position where they need help. And I think if we can start running more of the numbers, hopefully we can improve their care, their quality of life, and I think maybe the society in general. So I think there's light at the end of the tunnel, if you will. I think we're running up against time, so I wanted to thank you very much for being here. I'm looking forward to also following up, and hopefully we can help to maybe improve the situation even more. I think it's been quite interesting. So maybe some final thoughts from your end. How can we leave this in order to make sure that going forward we can do better?
Yeah, well, I think as I was listening really to both of you, just kind of wrapping up, the key thing here is leveraging technology to be able to help us make better informed decisions. And just as you were saying, I'm sitting here and going, oh my God, well, this is really technology at its best, right? And sometimes through the technology, it can help you see more that we as humans don't necessarily see. And so I think it's kind of bringing those two things together to allow us to have more data, and where it can bring in, it's getting to the point, I'm thinking you guys are using AI as well, right? Where you're looking at all these different types of variations and bringing it in to help someone to see, oh my God, well, that's really not what we're seeing. And that to me helps shed, more light on possibilities of treatment, and maybe earlier, and maybe even saving somebody's life before they go down a path of when it's too late, right? So,
is there anything that scares you about AI? Because there's like a lot of talk about AI these days, and some doom scenarios where the robots are taking over. Or do you feel that there's much more to gain, especially around health and in the short term, that it's definitely worthwhile going down that route?
So I think we have to go down that route. So I think the caution is that just as we did with the internet, just as we did with programming, we have to be cognizant and very intentional about the parameters that we put in. We have to be able to test that everything that we're asking the machine to do is not only ethical and viable, but we as humans are not perfect, and so therefore the machine's not going to be perfect, and so we have to make sure that we're kind of doing this balance. And so for me, I'm inquisitive. I think that we need to push it. It's topic of discussion in boardrooms. But I think unless we push it and we become familiar and not afraid of it, we're going to let it control us. And so if you let it control us because of fear, then that's even worse.
No, any thoughts?
Yeah, I mean, I think I'm somebody who likes technology, but by the same token, you have to be thoughtful and objective about what the technology is and how it's being used, and is it really accomplishing what you want it to do. I think AI in medicine has been shown to be a very useful tool, particularly in radiology. There's a lot that computers can do that the human eye is going to miss. And so, I think there are certainly potential hazards of AI that people need to be aware of and think about, but I think it's a valuable tool that we should also embrace and take advantage of.
On that note, thank you so much, and we'll stay in touch.
Thank you.